So now we come to the acute care genitourinary conditions. One is the urinary tract infection. It is mainly caused by the E. coli. For evaluating a woman with symptom of acute urinary tract infection, woman with more than one symptom of UTI, such as dysuria, frequency, urgency, hematuria, discomfort in the lower abdomen. So, if the patient is pregnant, yes, then see the section and need to end pregnancy. If no, if there is a recurrency, like if it is recurrent more than 2 times or equal to 2 times a year, or with risk factor for complicated UTI, if yes, do a urinalysis, urine culture to establish diagnosis. Consider initiating empirical treatment. With flank pain or fever, consider acute uncomplicated pyelonephritis, do urinalysis, urine culture to establish diagnosis, consider empiric treatment. C-section in acute uncomplicated pyelonephritis. If no, is it with vaginal discharge? If yes, low to intermediate probability of UTI, which is 20%, and one must consider sexually transmitted infection. So do pelvic examination, including cervical culture when appropriate, urinalysis, urine culture, urine chlamydia to establish the diagnosis. And with clear history of more than one or equal symptoms of UTI, acute onset of dysuria, frequency, urgency, hematuria, yes, then there is a high probability of acute urinary uncomplicated cystitis, which is 90%. You can start an empiric treatment without urinalysis. Urine culture. Perform dipstick urinalysis. If this dipstick result is positive, then there is a high probability of an acute uncomplicated cystitis, which is 80%, when we can start empiric treatment without urine culture. So if there is a low to intermediate probability of UTI, which is 20%, we can consider urine culture or close and clinical follow-up and pelvic examination, including cervical cultures and urologic imaging when appropriate. So conditions that define complicated UTI in someone: the presence of an indwelling urinary catheter or intermittent catheterization, incomplete emptying of the bladder with more than 100 ml retained during post-voiding, impaired voiding due to neurogenic bladder, cystocele, obstructive uropathy due to bladder outlet obstruction, calculus, urethral or ureteric strictures, tumors, vesico-urethral reflux and or other neurologic abnormalities, including surgically created abnormalities, chemical or radiation injuries of the uroepithelium, peri or post-operative UTI, azotemia due to intrinsic renal disease, renal transplantation, diabetes mellitus, immunosuppressive condition such as febrile neutropenia, HIV/AIDS, UTI caused by unusual pathogens, tuberculosis, candida, UTI caused by antibiotic resistant or multi-drug resistant organism, UTI in males, except in young males presenting exclusively with lower UTI symptoms and urosepsis. So for acute uncomplicated cystitis in women, this is suspected in premenopausal non-pregnant women presenting with acute onset of dysuria, frequency, urgency, gross hematuria without vaginal discharge. Antibiotics can be used for an acute uncomplicated cystitis. Empiric antibiotic is most effective approach in the management of acute uncomplicated cystitis. Primary kynetrofurantoin with 100 mg BID for 5 days per RM, 5 days lang. Metrofurantoin macrocrystals 100 mg QID for 5 days recommended due to availability, or fosfomycin 3 grams single dose P of single dose, quinolones, afloxacin 200 mg BID for 3 days PO. Yun, ciprofloxacin, ciprofloxacin ako. Ciprofloxacin 250 mg BID for 3 days PO. Ciprofloxacin extended release 500 mg for 3 days. OD ba siya for 3 days. Ang BID ang Cipro na 250. Levofloxacin 250 OD for 3 days. Norfloxacin 400 BID for 3 days PO. Alternative na sila ang beta-lactam, amoxicillin clavulanic acid, no? Plus dakong dose 625 mg 7 days BID. Cefuroxime 250, hala 250 ba sa 500 kay 1 OD ra. 250 mg BID for 7 days. Cefaclor 500 BID for Cefaclor 7 days. Cefixime 200 mg BID para kami kanang epilephrititis 200 mg BID for 7 days. Okay. Only if proven with susceptibility, trimethoprimsol, fametoxazole 160 over 800 BID for 3 days. Trimethoprimsol, fametoxazole 160 over 800 mg BID for 3 days should only be used for culture-proven uropathogens due to high prevalence of local resistance and high failure rates. Ampicillin or amoxicillin should not be used for empirical treatment given the relatively poor efficacy and very high prevalence of microbial resistance to these agents worldwide. Quinolones should not be used as first-line drug despite their efficacy due to high propensity of collateral damage. Dili sad ko para di magamit ng quinolones. Patients whose symptoms worsen or do not improve after completion of treatment should have urine culture, and patients whose symptoms fail to resolve after treatment should be managed as complicated UTI. Acute cystitis in pregnancy. In otherwise healthy pregnant woman, acute cystitis in pregnancy is characterized by urinary frequency, urgency, dysuria, gross hematuria, bacteriuria, without fever, and costovertebral ankle tenderness. Pre-treatment diagnostic test obtain a pre-treatment urine culture sensitive for midstream clean cut urine specimen. If the absence of urine culture, the laboratory diagnosis for acute cystitis can be determined by the presence of a significant polyuria defined as more than 8 pus cells or more than 5 pus cells for centrifuge, and non-centrifuge kay more than 8, with a positive leukocyte esterase and nitrate test on dipstick. Antibiotic treatment. Treatment for acute cystitis in pregnancy should be instituted immediately to prevent the spread of the infection to the kidney. So, ang recommended na mga treatment could be for pregnancy na for acute cystitis, cefalixin 500 mg QID for 7 days. Cefadroxil 1 gram BID for 7 days. Cefuroxime, pasabuntas gadudain ni. 500 mg BID for 7 days. Cefaclor 500 mg TID for 7 days. Cefixime, pwede ra. 200 mg BID for 7 days. Nitrofurantoin 100 mg QID for 7 days. Fosfomycin 3 gram single dose. Amoxicillin, pwede na. Amoxicillin carbonate 625 mg BID for 7 days. Okay. So, for an acute uncomplicated pyelonephritis in women, healthy women with no clinical historical evidence of anatomic or functional neurologic abnormalities with presence of fever of more than 38 degrees Celsius, chills, flank pain, costovertebral ankle tenderness, nausea and vomiting with or without signs of symptoms of lower UTI. Laboratory findings: urinalysis pyuria of more than 5 WBC for centrifuge, urine culture bacteriuria with counts of more than 10 1,000 equal to ang centrifuge na urine. Classic symptom of AUP in healthy adults is also applied to pregnant women. Pre-treatment diagnostic tests, urinalysis, and gram stain are recommended. Brain culture and sensitivity should also be performed routinely. Blood cultures are not routinely recommended except in patients with signs of sepsis. Biomarkers procalcitonin with vaginal, proarterial, natriuretic peptide C reactive protein are not recommended. Indication for admission: inability to maintain oral hydration or take medication, concerns about compliance, the presence of possible complicating conditions, severe illness with high fever, severe pain, marked debility, and signs of sepsis, signs of preterm labor. Antibiotic treatment for an acute uncomplicated pyelonephritis: ciprofloxacin 500 mg BID for 7 to 10 days. Ciprofloxacin extended release 100 mg OD for 7 days. Levofloxacin 250 mg OD for 7 to 10 days. 750 mg OD for 5 days. Afloxacin 400 mg BID for 14 days. Cipixem 400 mg 400 BI for OD for 14 days. Cipixem for an acute uncomplicated pyelonephritis. Comoxiclav kung gram positive 625 mg PID for 40 days. Halostanan 14 days pag acute uncomplicated pyelonephritis. Parenteral if patient is a febrile. Ceftriaxone 2 grams Q24 hours. Ciprofloxacin 400 mg Q12 hours. Levofloxacin 250 to 750 mg Q24 hours. Afloxacin 200 to 400 mg Q12 hours. Amikacin 15 mg per kilogram Q24 hours. Ampicillin sulbactam with positive gram positive 1.5 to 6 hours. Ertapenem if ESWL prevalence 1 gram every 24 hours. Piptas 2.25 to 4.5 to 6 8 hours. Gonna be golden. PMX SMX is not recommended for empiric treatment but can be used when organism is found to be susceptible in the urine, culture, and sensitivity. Quinolones are recommended as the first line for acute uncomplicated pyelonephritis not requiring hospital admission. Patients not requiring hospital admissions, an initial IV/IM dose of ceftriaxone or aminoglycoside may be considered, followed by any oral antibiotics. Patients with acute uncomplicated pyelonephritis requiring hospitalization, ceftriaxone, fluoroquinolones, or aminoglycosides are recommended as first empiric first line treatment. Intravenous antibiotic can be shifted to oral. Any of the listed oral antibiotics once the patient is afebrile and can tolerate without oral drugs. Carbapenem and piperazine and tazobactam should be reserved for patients with caused by multi-drug resistant organisms that are susceptible to either drugs. So primary ceftriaxone 1 to 2 grams, cefotaxime, ceftazidime 2 grams Q8 or solo. Alternative ampicillin 1.5 IV Q6 hours, preserpeptas 2.25 to 4.5. Oral cephalexin 500 QID 14 days. Cefadroxil 1 gram BID 14 days. Cefuroxime 500 BID 14 days. Cefaclor 500 mg TID 14 days, Cefixime 200 mg 14 days, amoxicillin clavulanic acid 625 BID 14 days. Post-treatment urine culture should be obtained after completion of antibiotic treatment to confirm resolution or the test of cure. The patient should be followed up for symptoms of recurrent infection, and monthly urine culture should be performed until delivery. The role of radiologic imaging, routine urologic examination, and routine use of the imaging procedures are not recommended. Consider early radiologic evaluation of the patient had a history of urethritis, urine of more than equal to 7, or urinary insufficiency. Consider radiologic evaluation of the patient if the patient remains febrile within 72 hours of treatment, or if symptoms recur, to rule out the presence of nephrolithiasis, urinary tract obstruction, renal or pyelonephric abscess, or other complications of pyelonephritis. Signs of sepsis is the presence of two of the following: temperature of more than 38 degrees Celsius or less than 36 degrees Celsius, leukopenia of less than 4,000 WBC or leukocytosis of more than 12,000 WBC, tachycardia of more than 90 beats per minute, tachypnea of more than 20 beats cycles per minute, CO2 of less than 32 mHg, hypotension less than 90/40 from the base, or drop of more than 40 from the baseline. The prevention of recurrent UTI and pregnancy, no pharmacologic intervention has been proven to be effective in the prevention of recurrent UTI and pregnancy. Non-pharmacologic intervention in the form of close surveillance, follow-up with urine cultures every 2 weeks and every 36 weeks has been proven to be non-inferior to nitrofurantoin in preventing recurrent symptomatic UTI and pregnancy. Cranberry juice is not recommended in the prevention of UTI as it does not reduce the asymptomatic bacteriuria and the presence and recurrence of UTI in the pregnant woman. So the treatment for an acute uncomplicated pyelonephritis in non-pregnant woman. For a healthy non-pregnant woman with acute uncomplicated pyelonephritis, assess the severity and likelihood of the illness and adherence to treatment. Septic to ill or likely to be non-adherent, then admit the patient to urinalysis, urine GSCS, do blood culture times 2 if septic, and start IV anti-empiric IV antibiotics. If no, do urinalysis, urine GSCS, treat as outpatient, start empiric oral antibiotics. Reassess the patient within 72 hours. Symptom improve on day 3. Shift IV antibiotics to oral once the patient is febrile or tolerate oral medications. Continue antibiotics for 10 to 14 days. Antibiotic choice should be guided by urine GSCS result once available. Repeat urine GSCS. Consider doing radiologic evaluation, urologic consultation. For asymptomatic bacteriuria in adults, positive urinalysis without symptoms. Urine leukocytosis defined as WBC of more than 5. Microscopic hematuria is defined as more than 3 blood cells as per high power field. Infection, malignancy, urolithiasis. Withhold antibiotics in situation in which bacteriuria is not significantly elevated. All diagnosis of asymptomatic bacteriuria should be based on the results of urine culture specimen that are collected aseptically with no evidence of contamination. Women defined as 2 consecutive voided urines with isolation of same bacterial strains in quantitative counts of more than 100,000. Single clean catch voided urine with 1 bacterial species isolated more than 100,000. In both men and women, a single catheterized urine specimen with 1 bacterial species isolated in quantitative count of more than 100 CFUML identifies bacteria. Indications for screening and treatment of asymptomatic bacteriuria. Patients who will undergo genitourinary manipulation or instrumentation are pregnant women. Period screening and treatment of asymptomatic bacteriuria is not recommended in the following. Routine screening and treatment for asymptomatic bacteria is not for healthy adults. Patients with diabetes mellitus, elderly patients, patients with indwelling catheter, solid organ transplantation, people living with human immunodeficiency virus, spinal cord injury patients, patients with urologic abnormalities. Optimal screening test for asymptomatic bacteria screening by urine culture. In the absence of facilities for urine culture, significant pruriria of more than 10 WBs, a high power field, or a positive gram stain of unspun urine more than 2 microorganisms in 2 consecutive mainstream urine samples can be used to screen for asymptomatic bacteriuria. Urine culture and sensitivity testing are not necessary when urinalysis is negative for pyuria or urine gram stain is negative for organism. Pyuria accompanying asymptomatic bacteriuria is not an indication for antimicrobial treatment among patients. For screening and treatment is not recommended. Asymptomatic bacteriuria in pregnancy in the presence that defined as the presence of more than 100,000 CFU per ml, the same uropathogen in 2 consecutive mainstream urine specimen, or more than 100 CFU per ml simple uropathogen in 1 catheterized urine specimen. Symptoms attributable to urinary infection should be absent. 2 consecutive urine culture is not visible or single is difficult. 1 urine culture is acceptable alternative for diagnosis in IABS in pregnancy. Indication for screening. All pregnant women for asymptomatic bacteria once between 7 to 17th week of gestation, preferably on the 16th week of AOG. Diagnostic test 9 to 17th week. Standard urine culture of clean catch mainstream urine is the test of choice in screening for asymptomatic bacteriuria. Urinalysis is not recommended in initial screening test, and urine dipstick for leukocyte esterase and or nitrate tests are not recommended for screening for asymptomatic bacteriuria. Absence of urine culture, urine gram stain of uncentrifuged urine, more than 1 organism per all emission field is recommended for screening for asymptomatic bacteriuria in pregnancy. Dip slide culture technique may be used as an alternative to urine culture setting where it is available. Antibiotic treatment. Antibiotic treatment for asymptomatic bacteriuria is indicated to reduce the risk of acute cystitis and pyelonephritis in pregnancy, as well as the risk of low birth weight neonates and preterm infants. Treatments with antibiotics should be initiated upon the diagnosis of asymptomatic bacteriuria in pregnancy. Among the antibiotics that can be used are nitrofurantoin, natriuretem, comoxiclav, cephalexin, cefuroxime, fosfomycin, TMP, SMX, not for first and third trimester, depending on the sensitivity results of the urine isolate. Cephalexin, 500 mg BID for 7 days. Cefuroxime, 500 mg BID for 7 days. Fosfomycin, 3 g single dose. Amoxicillin clavulanate, 625 mg BID for 7 days. Cefuroxime, 500 mg BID for 7 days. Nitrofurantoin, 100 mg QID for 7 days. TMX, SMX, 160 over 800 mg BID for 7 days. Tapos po na sa UTI. Ang candidiasis gani. The following factors should guide a physician in determining risk-benefit profile, and in deciding whether prophylactic strategies will be used, frequency and pattern of recurrence, patient's lifestyle, compliance, and willingness to commit to a specific regimen, plan for pregnancy, antimicrobial resistance, and susceptibility pattern of the organism causing the patient's previous UTI, risk of adverse events and drug allergies. Prophylaxis should only be initiated after counseling and behavior modification had been attempted in order to minimize antibiotic exposure and positive adverse effects. Antibiotic prophylaxis should be limited to women with recurrent UTI in whom non-antimicrobial strategies have not been effective and who prefer prophylactic antimicrobial therapy. Behavior changes. Behavior changes can be useful in antimicrobial sparing measures in the prevention of recurrent UTI. These behavioral measures include the following: post-defecation and anal cleansing, anteroposterior as always, and a movement to avoid contamination the periurethral area of the fecal flora, postcoital gouge or postcoital urination, liberal fluid intake, especially after intercourse, avoidance of tight-fitting underwear, use of alternative forms of contraception for women using spermicide containing contraceptives, biologic medication, cranberry juice, and cranberry products are not recommended for the prevention of the urinary tract infection. There is no available evidence to recommend coconut juice in the prevention of UTI. Application of intravaginal estrol cream once each night for 2 weeks, followed by twice weekly applicants for at least 8 months, or use of estradiol releasing silicone vaginal ring for 3 months is recommended for the prevention of recurrent UTI in postmenopausal women. There is insufficient evidence to recommend oral water hydration 2 to 2.5 liters a day in prevention or treatment of UTI. There is insufficient evidence to recommend drinking more water and avoiding before and after intercourse to prevent UTI. Immunoprophylaxis for recurrent UTI. Immunoprophylaxis using immune-active E. coli fractions is recommended for the prevention of recurrent UTI. The dosing regimen is once daily per orum for 3 months. A longer extended dosing regimen once a day for 3 months, rest for 3 months, 10 days per month for 3 months, and rest for 3 months may be associated with better control of longer term antibiotic prophylactic regimen. Prophylaxis is recommended in women whose frequency of recurrence is not acceptable to the patient in terms of level of discomfort or interference with the activities of daily living. Prophylaxis may be withheld if the frequency of recurrence is tolerable to patient. If a decision made to give antibiotic prophylaxis, either of the following: continuous prophylaxis defined as daily intake of low dose of antibiotic for 6 to 12 months. Postcoital prophylaxis defined as intake of single dose of antibiotic immediately after 6-month intercourse. Intermittent prophylaxis defined as self-treatment with single dose based on patient perceived need to evolve. So, nitrofurantoin, continuous prophylaxis ay 50 to 100 mg bedtime, postcoital 50 mg. Lagi kang cream 100 mg bedside. Cotrimoxazole 40 per 200 mg at bedtime. Cotrimoxazole 40 per 200 mg 2 times a week. Ciprofloxacin 125 mg bedtime. Norfloxacin 200 mg at bedtime. Ang kanyang cephalexin 125 to 250 mg bedtime. Consider intermittent self-administered therapy in highly educated, well-informed, motivated patients where the patient are able to recognize the characteristic signs and symptoms of UTI, are compliant with medical instructions, and have a good relationship with a medical provider. Breakthrough infection during prophylaxis should be treated empirically with the antibiotics recommended for uncomplicated cystitis other than the antibiotic being given for prophylaxis. Request urine culture and modify the treatment accordingly. Catheter-associated urinary tract infection (UTI) in patients with indwelling urethral or suprapubic catheter or in those undergoing intermittent catheterization is termed as catheter-associated urinary tract infection. This is diagnosed when fever or other symptom or compatible with UTI are present with no other identified source of infection. At least 103 colony-forming units of at least one bacterial species as present in single catheter urine specimen or in a midstream voided urine specimen. In a patient with an indwelling urethral suprapubic or condom catheter which has been removed within the previous 48 hours. Screening and treatment of catheter-associated asymptomatic bacteriuria are not routinely recommended. Screening and treatment of catheter-associated asymptomatic bacteriuria is recommended only for pregnant patients and those who will undergo urologic procedure. Data insufficient to make any recommendation regarding screening treatment. Diagnostic tests. Similar with general recommendation for UTI, it is necessary to obtain urine gram stain and culture before starting empiric antibiotic therapy. The presence or absence of odorous or cloudy urine unknown in catheterized patient is not also an indication of antibiotic treatment. Urine for culture and sensitivity. For a patient in whom catheterization is still indicated, the urine specimen should be obtained from freshly packed catheter prior to initiation of antibiotic therapy. Urine sample should be aspirated from the catheter port or if not present by puncturing the distal end of the catheter with a sterile needle and syringe after disinfecting the area without disconnecting the junction of the catheter and drainage tube. For individuals whose catheter can be or have been recently removed requires no catheterization, a midstream clean catch urine should be obtained. Urine sample for culture should not be obtained from collection bags. Urine specimen for culture should be processed as soon as possible, preferably within 1 hour of obtaining the specimen. If this is not possible, the urine specimen should be refrigerated. Should be processed within 24 hours. Antibiotics, since catheter-associated UTI is often a healthcare-associated infection, the choice of empiric antibiotics should be used with institution-specific depending on the local susceptibility patterns and severity of the patient's illness. 7 days of antimicrobial treatment is recommended for patients who have prompt resolution of symptoms and 10 to 14 days of antimicrobial treatment for patients whose response is delayed. So the antibiotic option for catheter-associated UTI, amikacin first line 15 mg per kilogram every 24 hours. Ertapenem 1 gram IV Q12 24 hours. For Pseudomonal carbapenem, imipenem, meropenem. Meropenem 1 gram, imipenem cisplatin 500 mg Q6 hours. Vancomycin IV Q12 hours. Colomycin, tetracycline 100 mg IV loading dose, then 50 IV Q12 hours. Ampicillin 1 to 2 grams IV Q6 to 8 hours. Cefixime 1 to 2 grams IV Q8 to 12 hours. Ceftazidime 1 to 2 gram IV Q8 hours. Peptaz 4.5 IV Q24 hours. Levofloxacin 750 mg Q24 hours. Approach the presence of an indwelling urinary catheter. Whenever possible, the indwelling catheter should be removed to help eradicate the bacteria. For patients in whom indwelling catheterization is necessary, long-term indwelling catheter should be replaced with new catheter before initiating an antimicrobial therapy for symptomatic UTI. Strategies for reducing the risk of catheter-associated UTI. The use of indwelling catheter only when necessary. Use antiseptic technique including appropriate hand hygiene with sterile gloves. Allow only trained personnel to insert the collar catheter. Properly secure catheters from and after insertion to prevent movement and infection. Maintain a closed sterile drainage system. Maintain a good hygiene. Maintain unobstructed urine flow. Remove catheters when no longer needed. Do not change indwelling catheter or drainage valves at fixed interval. Condom catheterization is an alternative to indwelling catheter for many patients in whom urinary catheter is necessary, provided post-void residual urine is minimal and the patient has no cognitive impairment. Suprapubic catheterization may be an alternative to urethral catheterization when there are excellent support mechanisms from the surgical and caregiver staff. The following should not be used in effort to reduce catheter-associated UTI because their use has not been shown to prevent the development of subsequent bacteriuria or symptomatic UTI. The use of antibiotic-coated catheter, routine use of systemic prophylactic antibiotic lateral insertion during and upon removal of indwelling urinary catheter or bladder irrigation with antimicrobial agents. Routine addition of antibiotics or antiseptics to drainage bag and reflux vents and valves. Daily mental care, changing the catheter and drainage bag at arbitrary fixed interval. So for the urinary candidiasis, Candida is defined as the presence of the Candida species regardless of the colony count. In properly collected urine specimen taken on 2 separate occasions at least 2 days apart. The presence of Candiduria may present a whole spectrum of pathologic states, from invasive renal parenchymal disease, fungal boils, or obstructed ureter and lower urinary tract infection. To begin, conditions such as colonization, the presence of these cells or hyphae in microscopy, especially when there is pyuria, may be a clue that fungal infection is present. However, this finding should be correlated clinically. The first line treatment is fluconazole 400 mg loading dose, then 200 mg per day for 7 to 14 days. The route of administration depends on the patient's status and oral tolerability in certain clinical situations such as azole use, refractory infection or suspicion of drug resistance with fluconazole. Patients with Candida glabrata infection, IV amphotericin B at dose of 0.3 to 1 mg per kilogram per day can be given. For patients who will undergo urologic procedure and in whom Candida was found to be present, fluconazole 200 to 400 mg, 3 to 6 mg per kilogram daily, or amphotericin B 0.3 to 0.6 mg per day milligram daily for several days before and after procedure is recommended. Bladder irrigation in the management of urinary candidiasis. Bladder irrigation with amphotericin B can be used as adjunct therapy to systemic antifungal agents in the presence of refractory cystitis. When used, a continuous irrigation of amphotericin B at a concentration of 50 mg per liter of still water for a period of 5 days is recommended.